Good morning, everyone. My name is Caoimhe Gleeson, and I'm from the National Office for Human Rights and Equality Policy. I'm delighted to welcome you all to our autumn series, From Policy to Practice, Consent, Assisted Decision Making and Tools for Practice. Today's session is on why consent matters in maternity and pregnancy care. The driver for this webinar was the National Maternity Experience Survey, which identified consent as a key issue for some people who use maternity and pregnancy services. While the survey was launched some weeks ago, we felt it was important to specifically address the issue of consent, which we are attempting to do so today. We have an excellent panel of experts who will address this issue from a number of perspectives. Our chair, Professor Mary Donnelly, and Dr. Phillip Crowley will say a little bit more about this shortly. We're joined today by a very diverse audience who have a personal and professional interest in this subject. So welcome to all of you from all corners of Ireland and those who are joining us from outside of the HSE and indeed from other jurisdictions. Particular welcome to all of the students who join us today, and we know there's a number of students from throughout the country as well. This webinar series is being organised by our office and the National Quality Improvement Team. Our office is leading the preparation for the HSE for the commencement of the Assisted Decision Making Capacity Act, and we also have oversight of the National Consent Policy, which includes the Do Not Attempt resuscitation policy. We also have responsibility for a number of other human rights and equality policy issues. We've hosted a number of webinars already this autumn, which you can still access on www.assisteddecisionmaking.ie, which details will be in the chat box. If there are specific related topics or issues you'd like us to address over the coming months or into the future, please get in contact with Jacqueline Grogan or Orla Brannigan, and there'll be details in the chat box as well. Equally, if you have specific expertise in this area you wish to share, please also get in contact with us so we can collaborate with you. The chat box is open. That's that box at the side of the panel. We will try and help you with your technical issues through this function. Jacqueline and Orla will be providing support to us today. But if you can please post your technical questions to all panelists, not just the host. If they just go to the host, then she won't be able to address some of those issues, just to be able to spread some of the load. Professor Mary Donnelly, who is our chair for this morning's session, will go through a number of housekeeping issues with you shortly. But first, I'd like to hand you over to Dr. Phillip Crowley, who's the National Director of the National Quality Improvement Team, and he's also acting National Co-Lead on the public health response to COVID-19. Phillip will open this morning's session. We're delighted that he's able to join us for some part of this. So thank you, Phillip.
Thank you very much, Caoimhe, and good morning, everybody. This, as Caoimhe said, is a part of a series of webinars that the Office of Human Rights and Equality Policy, which operates within my own team, have been running. And they've been really wonderfully attended, very successful, very good content. I think the degree of interest in these webinars demonstrates, I think, the commitment we all have to getting issues of consent, issues of decision-making, people's rights, putting them at the forefront of how we actually deliver clinical care and practice. So it's been a very positive journey that we've been on. And today, I think we're going to look at what consent means in the context of pregnancy and maternity care. Obviously, building on the National Maternity Experience Survey, which is an extension of the Patient Experience Survey that was extended to maternity services for the first time in 2020, which is a very positive, first of all, development that we have expanded the assessment of experience into the area of maternity care. But also, I think, the survey itself came up with a lot of very positive findings about the really wonderful care that almost always is delivered in our maternity services. But the survey did raise some issues around choice, around support around childbirth and after birth and after giving birth, and also some issues around support around kind of psychological well-being around the issues of childbirth. And I think these are all issues that the services will be addressing and that we might get into a little bit today as well. And we're going to have some recorded stories of people who will really demonstrate, I think, the importance of issues of consent to all of us if we needed such convincing. We have a wonderful group of speakers and a great audience with an awful lot of expertise. So I really hope that during this webinar, you really can get stuck in, can participate, and that you can kind of use, as Caoimhe said, the chat function to direct comments and questions, and we'll record the chat function then, and so we can distill your wisdom that you share through that chat function as well after the event. The aim, obviously, in the end of the day, is to improve practice and to improve the experience of people who use our services, and to really develop fundamentally person-centered care. That's care that is centered on the needs of those who use our services, but also on ensuring that those who provide our services are well cared for as well. If you don't look after our staff, then they can't look after our service users. So I think you're going to really enjoy today's session. I think it's going to be a very positive session. I really like to thank all our speakers. Thank you for participating, and thank our chair, Professor Mary Donnelly, who's been a wonderful supporter of our work in the area of human rights and equality policy. So I'd like to thank you for your time and your commitment that you demonstrate in participating today. I'd like to hand over now to Mary, who will take us through the rest of the morning, and wish you the very best of luck. Thank you very much.
Thank you very much, Philip. And on my own behalf, just to say how incredibly impressed I am with the work of the Human Rights and Equality Unit within the Quality Improvement Division of the HSE. They've been doing phenomenal work in improving the experience and working to improve the experience of everybody who uses the service, and also to ensure that it is underpinned by human rights values. And in relation to pregnancy in particular, one of my jobs is to jointly chair, together with Professor Sean O'Keefe, the advisory group on the National Consent Policy. And in 2019, we received a query. We're working at the moment to do a complete revision of the policy. We're working through various changes. But we received a query in 2019 from a person who was pregnant, asking, well, what difference does it make now that the Constitution has changed? Because the original consent policy was developed in the context of a particular constitutional situation. And we said, well, we're reviewing the policy, and they pointed out, well, that's not much good to me, because by the time you've reviewed the policy, my baby will have been born. So we addressed the matter, we sought legal advice, and we have now, and it's the 2019 version of the policy, has changed the policy to confirm that pregnant women, pregnant people, have the same consent rights as everybody else. You might say that should be obvious, but post-referendum, it is obvious, and it is now clearly stated in the consent policy. So that's just a little bit of background and to the work we've been doing in relation to this. Obviously, we're going to be digging a lot more deeply today. I'm going to do some very quick housekeeping points, if I may. Let me see. First one is you're all on mute, so don't worry about muting yourself. To reiterate what Caoimhe says, if you have technical issues, flag it in the chat box. Start using the chat box early, I would suggest, because in terms of questions, what I will do is when we come to question time, I'll go back right up to the start of the chat box. So if you want your question to be heard, the quicker you start using the chat box, the better. It's open. You can address, as I say, technical issues, but you can also address issues to the panelists. As Caoimhe said, address everything to all panelists and not just the host, and that's to ensure that we can all see what's going on. One or two other small issues to mention. We are recording the seminar. So just to be aware of that, and obviously that means that it will be available for you to view online at the assistedDecisionmaking.ie site, along with all the other seminars which have been recorded. We have CPD points. We've been awarded CPD points from RCPI, have given 2 points, and CEU have given RCPI points, 2 points, and CEU points from the Nursing and Midwifery Board at 3 points. You'll get an email confirming your attendance. Details of that are also in the chat function. Without further ado, and as I say, some of those details will be mentioned in the chat function. We have a very full lineup today. We have a very experienced and very excellent lineup. We're very excited about the lineup we have because it is such a very rich lineup of speakers. We will be keeping people quite strictly to time, and we'll be asking our speakers to stay quite strictly to time. some of you will hear a little bell ringing, and that is Marie, who is in the background there, who's timing everybody to ensure that people keep to time, although I know you all will. And the reason for that, of course, is to ensure that we have the maximum amount of time for questions. So without further ado, I want to turn to our first speaker, and we're very, very fortunate that Dr. Rona Mahani has agreed to join us today. Dr. Mahani is currently the Executive Director of the Women and Children's Clinical Academic Directorate within Ireland East Healthcare Group. She is, I think, needs very little introduction. Most of us know her very well, as of course her role as Master of the National Maternity Hospital, a role she fulfilled from 2012 to 2018. Dr. Mahani is a fellow of many institutions. She is very, very highly regarded, both academically and for her work in relation to advancing women's health. So I would like to thank her very much for joining us and turn over to her, if I may. Thank you, Dr. Mahani.
Thank you so much, and thank you so much for inviting me today. It's such a great idea to have this conversation, and I agree, I commend the HSE for their work in equality and their work on behalf of women, and it is wonderful to see finally a patient experience survey shared with us. And I'm just going to try and share my slides with you, and wonderful to get that conversation started. So just 1 second now. So why does consent matter in pregnancy and maternity care? And it seems awful even that we have to ask this question, because it's absolutely fundamental to every single human person. At the core of this is autonomy and bodily integrity of every single individual. But underpinning this is our respect for life, our respect for each individual person. And this is something really that must be championed and never compromised, because all too often we see the adverse outcome when it is, in terms of mortality, in terms of morbidity, and in terms of psychological suffering, and just the sheer diminishment of a human being. But just coming back to the whole concept of integrity and rights, you know, we know that this is something in our own country that in fact is enshrined in Article 43 of our Constitution. And the state guarantees in its laws to respect, and as far as is practical by its laws, to defend and vindicate the personal rights of the citizen. And the Medical Council guidelines put this even more simply, and this couldn't be more simple. Patients have the right to decide what happens to their own body. And that must be a fundamental principle of every element of care that we give to individuals. And it's more than that. I mean, you know, the right to have informed consent, the right to agree to something that affects our body, our integrity, has, of course, a basis in civil, constitutional, and indeed in criminal law. And our Supreme Court tells us that the requirement of consent to medical treatment is an aspect of a person's right to bodily integrity. UK similarly tell us every human being's right to life carries with it, as an intrinsic part of it, rights of bodily integrity and autonomy. The right to have one's own body whole and intact, and the right to take decisions about one's own body. But it's interesting, there's been a real paradigm shift in this area. And, you know, the current healthcare, you know, we look back and we look at healthcare systems that were founded on a very paternalistic model in which physicians maintained authority over health-related decisions and information. And sadly, you know, this remains to some element true today. The American College, you know, in various publications describe this historical imbalance of power. And we're all familiar, anyone who's been in hospital knows when you cross the threshold of that hospital door and you're put in a hospital gown, you lose so much of yourself, you become so vulnerable, and your whole identity almost is at question at the very time when you're about to have either an operation or some really serious treatment that has a huge impact on you as a person and on your body. It's really important in obstetrics because this is an area of medicine that has such high intervention rates. And just to give us some idea, around 80,000 women become pregnant every year. 1 in 5 women will miscarry in the first trimester of pregnancy. They may have either medical procedures, they may have surgical procedures in this context, ectopic pregnancy. We've 70,000 babies or 60,000 babies now born annually, with a perinatal mortality rate of around 5 per 1,000, which is actually excellent in international standard. And we have babies surviving as tiny as 24 weeks and weighing just 500 kilograms, who also have a huge amount of medical care given to them at that very early stage of their survival. We have an instance of severe maternal complication of 4 per 1,000, and very tragically a maternal mortality rate of about 8 per 100,000, with the majority of deaths arising from indirect causes in pregnancy. But almost 1 in 3 women in Ireland at the moment are delivered by caesarean section, and almost 1 in 8 first-time mothers in labour require instrumental assistance to deliver. And 1 in 5 infants will require some form of resuscitation or neonatal intensive care. And when we look, just to put it in graphic terms, we can see here, this is the rise in caesarean section rate between 1994 and 2016, and that trajectory continues today. And yet we've had no change in the prevalence of cerebral palsy, which really is the one thing we would love to be changing. This little baby in our neonatal unit, and you can just see the level of care that is required, the level of intervention, the level of care that this poor little person receives. So I would argue that maternity care is unique. We deal with 2 lives that are inextricably linked by a very complex physiology. The rising intervention rates underscore the importance of ensuring that women have the facility to make informed choices. And our decision-making reveals numerous systematic and individual benefits. We know that when women are engaged with their care, when they have a sense of control, when they have the right information and they're making decisions, they're more comfortable, less anxious. And there's lots of evidence in research now coming on that outcomes are actually better. So this isn't something that's nice to have or is polite or respectful. It's fundamental to good outcomes in care and to patient experience. There are numerous examples of recourse to the courts, of course, in very complex cases, because this is such a complex area. And perhaps one of the most dramatic cases was the really tragic case of Miss P, a woman who had suffered a brain death at around 14 weeks gestation, but was kept somatically alive in order that her fetus might survive. This was an exercise in futility, the High Court says. Medical evidence was overwhelming in terms of its opinion that this fetus could never survive, and yet a father had to go to the High Court to seek consent to let his daughter go. I will never forget that case, but it demonstrates in stark terms how we are in pregnancy, how 2 lives are inextricably linked, and what is that complexity that surrounds decision-making when we are giving care. And there's a huge cost. You know, about 70% of medical negligence claims arise from the area of maternity care, and so frequently what is at stake is communication, consent, patients who haven't understood treatment or doctors who haven't explained properly what are the options and what is happening. But the cost is much greater in human terms, in women's experience, in the trauma they suffer having children, and in the many years it takes sometimes to come to terms. And I've had many women, long after they've given birth to a baby, who still have questions and issues surrounding that. So the hallmarks of maternity care, it's a clinical balance of 2 lives, high level of intervention, procedure dependent. Every birth is a procedure, and these procedures are time dependent. And complications arise unpredictably, and they arise frequently, and those complications can be catastrophic. From an infant death, a maternal death, or to the very severe morbidity. And, you know, we all understand the human cost of outcomes like cerebral palsy when we see our children so damaged, and we see the effect that has on their families and indeed on broader society. But there's been a real paradigm shift in terms of how we look at self-determination, how we look at consent. And ironically, it was in the area of gynecology that we first began to explore this formally in the courts. And I bring you back to 1914 in New York City, and Schlorendorf versus the Society of New York Hospitals. And this case was about a woman who had a fibroid. She consented to have an examination under anaesthetic, but when she woke up, she'd had a fibroid removed. And this case went to court, and it enshrined really the patient's entitlement to self-determination and the mandatory protocol to obtain consent. Later on, again in America, 1957, Salgo versus Leyland, Stanford Junior University Board of Trustees. This case, which was about a man who had an aortogram and became paralyzed as a result, enshrined the importance of patients being informed in order to consent to medical care. So the court established here the legal doctrine of informed consent. So it's not enough just to say, you're going to have this operation, is that okay with you? The patient has to really know what is going to happen to her when she gives consent for care. This case undermined itself slightly by allowing a certain amount of discretion, and so perhaps it diluted its effect. But throughout the 1980s and indeed 1990s, we saw a shift from physician authority to patient autonomy. And this is coupled with a public and political movement that emphasised patient access to information, to choice, and personal control regarding individual medical care. So what is informed consent? This is consent that's given to a person with capacity, and women in receiving maternity care are no different to anyone else. This consent must be given voluntarily, without any element of duress, and it must be given with the requisite information of the risks, the side effects, and indeed the alternatives, so that the patient is able to make an informed decision as to whether or not to proceed with the treatment. What it isn't signing a form that might have a long scroll of potential complications, 5 minutes before an operation. It's a process of information transfer, it's a process of education, it's a process of partnership, or at least that's what it should be, and that's what we should strive for. The essential components of informed consent in this table, so comprehension. Clinician must be sure the patient really understands the situation, possibilities, and uses language that's understandable, not the usual medical jargon that we're all guilty of, and I'm just as bad as anyone. They must give adequate information, the diagnosis, the prognosis, the alternative treatment choices, including no treatment. And there must be freedom of choice to give consent freely, intentionally, voluntarily, to authorize the provider to perform the procedure. There must be no coercion, no pressure from forces beyond herself, and she must be able to choose among options other perhaps than those that might be recommended. There are some exceptions to the general rule of consent, of course, and that would be in the case of an emergency where there's no evidence of what a patient wishes and no way to ascertain them. In that case, a doctor is obliged to treat a patient in his or her best interest, thus touching on the doctrine of necessity, I suppose, and also in an outbreak of notifiable disease. And we're thinking a lot about that with our current pandemic situation, in which case legislation requires individuals can be detained for public health reasons. And of course, there are many cases that a court of law may order medical treatment in certain situations. And in fact, in the area of maternity and with young children and babies in the unit, we have frequently recourse to the High Court, which reflects the complexity of the decisions that must be made. So just to recap, information, it's got a number of components: the diagnosis, the prognosis, the options, the reason, the purpose of treatment, benefits and risks, alternatives, and even local limitations. So for example, a unit might not be able to offer treatment. All of that should be outlined to a patient. But as I said, it's sharing information, not signing a form. The medical council are clear on this, and they tell us that as a doctor, we have a duty to help patients to make decisions for themselves by giving them information in a clear and easy to understand way. And that might involve translations, it might involve visual aids, it might involve involving family members to help explain, videos. There are lots of materials available to us that can really help us help patients understand what is the nub of their issues. And patients have the right to have an advocate of their choice during discussions about condition and treatment, although it's ultimately patients who will be the determinants of their treatment. In terms of what it is we must inform a patient, again, it's the area of maternity and care, although this is a man in Walsh versus Family Planning Services Limited who went for a vasectomy and had chronic pain. And in this was explored the concept of what are the risks we have to tell, how much do we have to tell a patient? And so we must inform patients of any possible harmful consequences arising from the operation. Yeah. I apologise now. My slides seem to have got stuck, but we also come on then. I'm not sure if we can restore those slides, but I can keep going. Can you hear me?
Perfectly. Thank you, Rona. If you keep going, and Jacqueline will be working away in the background, hopefully trying to restore slides and things there. So if you keep going, Rona, that would be excellent. Thank you.
That's great.
Rona, do you want me to share your slides? I think we've lost Rona. She's dropped out, unfortunately.
Okay, so what we might do is we might give it just one moment, see does Rona come back in, and if she doesn't, we may move on to our panelists, and then we can come back to Rona when she re-emerges, if that's all right with everybody. I just, as I say, leave it maybe just one moment more because she may pop back in again. But if not, I think what we will do, because again, of course, we have a lot of exciting material to get through. So we might turn, I think at this point, to Grania, if that's all right. We're very, so in other words, we're going to move into the panel discussion, but then we will move back and let Rona finish when between panelists as we work forward. So in terms of our panel discussion, we have several very experienced panelists who have a great deal of shared knowledge. I'm really excited to introduce Grania Milne. Grania has been Director of Midwifery for Our Lady of Lourdes Hospital in Louth County Hospital and Our Lady's Hospital Navan since January of 2018. She's led her team through some fairly challenging times, and indeed I fear we'll have to lead them through some more challenging times. She's an advocate for midwives and women's choice, and her particular interests are normality in pregnancy, fetal growth restriction, gyne-oncology, and I love this, anything to do with Donegal. So thank you very much, Grania, for joining us, and we very much look forward to hearing what you have to say.
Thanks.
Can you hear me now, Mary?
Perfectly.
Thank you. And thank you for giving me the opportunity to present on behalf of Our Lady of Lourdes Hospital in Drogheda and Louth County Hospital in Navan, where I'm the Louth County Hospital in Dundalk, where I'm the Director of Midwifery. And I'm presenting today on hearing the voice of the pregnant person and the role of the midwife. So thank you for giving me that opportunity. Just want to move on the slides here now, sorry. Again, just to move on. Apologies. Okay, so today I want to talk on the role of the midwife, professional standards, policy and legislation, and hearing the voice of the pregnant person. So to start off, I suppose, is the role of the midwife. And I will read the definition of the role of the midwife, or the definition of the midwife, to you, because it's really important and a distinct profession. So midwife is a person who has successfully completed a midwifery education programme, duly recognised in the country where it is located, acquired the requisite qualifications to be registered, and or legally licensed to practice midwifery and use the title midwife, and who demonstrates competency in the practice of midwifery. And that is from the Nursing and Midwifery Board of Ireland from 2015. So it's a professional registration. And just in, it was only in 2011, following the Nurses and Midwives Act, that midwifery was actually recognised as a separate profession. And in that act, it said, for the avoidance of doubt, it is hereby declared and recognised that midwifery is a separate profession to nursing. And Rona touched on it earlier in the uniqueness of the role, and it is quite a unique role for midwives. As Rona mentioned, we are dealing with two lives. And midwives deal with pregnant persons, not only antenatally, interpartum, postnatally and beyond, but now have gone into the role of preconceptual care as well. And the uniqueness of the role is that midwives are caring for women 24/7. They are the main carers of pregnant women. And it is said that some pregnant women need a doctor, but all pregnant women need a midwife. And in our MLU here, in Our Lady of Lourdes Hospital in Drogheda, we have a dedicated team of midwives who care for women completely from booking to their homes 1 week after they have their baby. So it is a unique and special role. The midwifery philosophy is that the ethos of midwifery is to work in partnership with women. So it's not about making decisions for women, about women. And I love that term, nothing about me without me. And that is that we as midwives work in partnership, and that is linked to the whole ethos and the whole idea of why we're here today. And it's about hearing the voices of the women. Apologies, now it's sticking there, the slide again. Okay, so in relation to midwifery values, again, it's based on the same principles that the woman is the primary decision maker in her care, and that midwives value this empowerment of women to assume responsibility for their health and the health of their families. So again, it's about giving the information, not making the decisions on behalf of the women, but allowing them to make informed decisions. So that's, I suppose, what we know about from NIMBY about what a midwife is. But interestingly, as part of the International Day of the Midwife a number of years ago, we actually asked the women, when you hear the word midwife, what do you think? And I suppose two particularly stand out, that we are a spokesperson for mothers as midwives, and that we are people that know what we are talking about. Now, interestingly, we're not all large women about 50 with buns in our hair, but that's what one woman thought when they heard the term midwife. But I suppose if you ask midwives what they think, what a midwife is, and again, Rona mentioned it, it's that word advocate. Like an advocate is a person who helps and supports another person and will act on behalf of the other person, and to empower a person by supporting them to put forward their views and claim their entitlements if necessary, and act as a representative for that other person. And I suppose that's possible because of that rapport that has been built over the whole length of the pregnancy, from, as I say, conception to birth. Moving on, I suppose, to professional standards. We have our practice standards for midwives 2015, and they're clearly aligned to the Code of Professional Conduct and Ethics for Registered Nurses and Midwives 2014. And just, I suppose, very briefly to look at the Code of Professional Conduct and Ethics for Nurses and Midwives, you can see the 5 guiding principles there. And they're hugely important in how, as midwives, we can listen to the voice of the pregnant person. And I'm just going to go through, I suppose, some of those very quickly. But again, it's just to say that they are then supported by what I mentioned, the values, our standards of conduct, but the overwhelming theme is patient safety and the safe delivery of the mother and baby. So just to say that principle 1 in the code is respect for the dignity of the person, and that is aligned to practice standard 1, which underpins a philosophy that protects and promotes the safety and autonomy of the woman. Principle 4 is trust and confidentiality, aligned to practice standard 4, and that midwives work in equal partnership, which I mentioned before, partnership with the woman and the family. And principle 5 is about collaboration with others, that midwives communicate and collaborate effectively with women, their family, and as part of the multidisciplinary healthcare team. And this is all, I suppose, all ties in nicely to the principle of hearing that voice of the pregnant person and the role of the midwife. I suppose moving on to national policy and legislation, and again, Rona touched on the National Consent Policy, which 2013 HSE, I'm not going to go through obviously in detail, quite a large document, but just to say that it clearly outlines the definition of areas where consent must be obtained. And that's really important, as I say, for midwives, and that's reflected in our Code of Professional Conduct and our practice standards. And there are some points, I suppose, to consider for midwives, and I'm not going to dwell on them given time, but I do, and Rona again has touched on that language, the repeating information, the use of visual aids. But really, I suppose, and again, it's not the forum for discuss issues in relation to COVID-19 per se, but another term when we say the word midwife, it's with woman, and that can't be more evident than what we're going through now with COVID-19, and with the visiting restrictions that have to have been imposed to protect all staff, patients, and visitors. That midwife now is the core, the centre of being the support person. And again, hugely important that that trusting relationship has been built up over that time from booking to birth, and that the midwife can play a key role in supporting the pregnant person in decision making. And again, a very detailed slide, but I just want to pick out some words that is in the National Consent Policy that relates to pregnancy, and that women need sufficient information to make those decisions. They need sufficient information about the nature, purpose, and benefits and the risks of an intervention or lack thereof on their health and life, but also the same is for the benefits and risks for the health of their fetus and the benefits and risks of that child when that child is born. All of this information is required to make an informed consent. And again, I've just listed, and it's an endless list of examples of consent in pregnancy, and I'm not going to go through them, obviously, for a whole, for the time that we have now. But it all boils down to you cannot do anything. You cannot put a hand on a pregnant person without gaining consent, and that is really important in the role of the midwife in all that we do and how close we get to that woman. But consent is at the heart of everything. And again, if we had more time, there's issues around verbal consent and written consent. But, I suppose it's to keep that part in mind, but consent is hugely important. The second document, just the creating a better future together, the National Maternity Strategy. Just want to quickly talk on that as well. And the National Maternity Strategy is a 10-year plan for our maternity services. And in the National Maternity Strategy, they also talk about the respect for a person's autonomy, about bodily integrity, about the consent should be voluntary and informed, and that the person has sufficient capacity to make that the consent and that decision, that the decision is informed. And also, I suppose, in relation to pregnancy, we have ample opportunity during the antenatal period to discuss foreseeable events and, potential problems that may occur in labour. Again, it's about that continuity of carer that midwife has, but also during that time, to discuss unforeseen events that may occur. And I suppose when you've built up that trusting relationship during the pregnancy, labour does not go all the time, as expected. So if something does happen and labour can be unpredictable, that decisions must be made within very tight timescales. And if we have had that communication, that good communication and decision making throughout pregnancy, and in that scenario, then the person can make an informed consent. So there's also refusal to consent, and cases may arise where a woman disagrees with the treatment recommended. And again, it's about that trust is necessary for such discussions and mutual respect in decision making. And the final document, just to touch on, is the National Standards for Safer, Better Healthcare, which also incorporates consent and making every contact count, building that partnership between women. And just, I don't want to go in too much to the findings of the maternity survey, because I know that's going to be discussed later. But the highest scoring questions were in relation to words that are respect, dignity, confidence, trust, and questions always answered. And in that, I suppose in relation to the National Maternity Experience Survey for Our Lady of Lourdes Hospital, I just wanted to make some very quick comments in relation to what the women have said. And again, to pick out words, they were kind, compassionate, non-judgmental, amazing. They're the ones that I find that really listen to women. They made me feel safe and ensured I was informed in all areas. And it's that piece about making every contact count, and midwives have that opportunity. just go on to my last slide here because I heard a little bell ringing in my ear. So in conclusion, I just want to say that I'm absolutely delighted to get the opportunity to share with you the hugely important role of the midwife in relation to consent. And I have outlined the professional guidance for midwives, the national policy and legislation, and the National Maternity Experience Survey. And I do want to say that, you know, the comments back from the women in this survey overwhelmingly positive. Like 85% nationally had a good or very good experience in that national experience survey. Our Lady of Lourdes, 90%, very proud. But I do want to say that as the director of midwifery, I am extremely proud of all the midwives who continue to provide the highest standards of care during these challenging times, keeping that pregnant person at the heart of everything we do. And I just want to say thank you very much for listening. And I just feel midwifery is the very stuff of life. And if you're interested in Call the Midwife, that's a line from that. Thank you very much.
Fantastic, Rania. Thank you very much. That was marvellous. We might go back now, and actually, they work really well together. Actually, we see beautifully medical professionals and midwives working together. So it's lovely now to go back to Rona to give her the opportunity to finish her paper. So thank you, Rania, and thank you very much, Rona. Handing back to you now.
Thank you so much. Apologies, everyone. It's just the gremlins here, but we'll just come back, hopefully. Are those slides coming up?
Yes, we're still in. You need to go into slideshow if you want.
Yeah, very good.
Perfect.
I'll just click through till we come to where we are. Great.
Yeah, working very well.
Apologies again. So really, I was on the whole concept, and fundamental to consent is informed consent, and I can't say it enough. We have an absolute duty to give patients proper information about procedures so they can make those decisions about whether procedures are right for them. So we came in that first case at looking at what we had to tell patients, and again, it's actually a dental case, Gagan versus Harris, but in this, Nicholas Kearns kind of gets down to that material risk associated with a proposed form of treatment. That's a consideration of the severity of the consequence and the statistical frequency of the risk. So we owe it to our patients that we give them a really good understanding of whether they're likely to suffer very morbid consequences or whether the recovery is going to be very difficult. What are the complications arising from a procedure? So they're with us as partners making that decision. And we move away from the years ago of whether you're having a major operation or a minor operation. We think of it and the lack of information that we gave patients. And again, we went through kind of in broad terms, it's very important that someone has the capacity also to make that decision and that we are respectful of that. So again, we've talked about simple language and doing everything we can to help people understand and also to help people understand the consequences of not receiving treatment, which sometimes is just as important as receiving the treatment, and that patients are able to retain this information and really understand it. So sometimes the concept of cognitive ability, it's interesting, giving consent in labour, and it's just a personal observation, when patients agree with us as obstetricians and we think a cesarean is necessary, very often we have little difficulty, but when patients don't agree with us, that's when we wonder about capacity. And I think it's something that's worth reflecting on as clinicians. But we do need to understand that there is comprehension there, that there's retention, assimilation of information, and that a patient has had the chance to weigh treatment information, alternative choices, and likely outcomes. So there's balance coming to the decision. And I'm going to make the point excellently, antenatal care, all of the visits before a baby are born are ideal opportunity for us to have a long conversation, not simply a short conversation one day in 5 minutes, but where we can anticipate complication that we have given that. There's a very good example of this, Fitzpatrick versus Kay. It arises quite a number of times in obstetrics, and that is a case of, this was the case of a lady who was Jehovah's Witness who had a very severe postpartum hemorrhage, required transfusion but was refusing blood transfusion, and the issue of capacity came up in this. She believed that Coca-Cola and tomatoes would form as just as good a treatment. So the High Court found that this woman perhaps did not have the capacity to make this decision because of failure to transfuse her would lead to her death. And given the seriousness of the nature of this consequence, the court found in favour of the clinicians and the ability to transfuse her. But it's very important that we do our utmost to help equip women to make these decisions as partners. The issue of intellectual disability arises, and it's a very important one because we often look after people who may have either physical or intellectual ability, but it's very important. And we know there's been a sea shift and change in how we consider this issue. It's really important that we understand that intellectual disability does not necessarily render a person incapable of consent. It must be our aim to maximise the ability of this person to consent and to look at the legal frameworks that might be available to us to assist this. And obviously we have got the recourse to court applications in very challenging cases. And I know the Assisted Decision Making Act is to be commenced, and this will hopefully streamline decisions by, with, and on behalf of those who have reduced capacity. But we must assume and label people and assume they are not capable of giving consent. And again, as Gráinne has said, we have our HSE policy document, and indeed the National Maternity Strategy is clear that where there are implications for the health and life of the baby, then the HSE's National Consent Policy recommends that legal advice should be sought, and the courts litigate quite frequently. I think it's also important, we must improve our clinical practice. At the end of the day, consent matters because it's fundamental to our respect for our patient as an individual, as a human being. But it's time we started looking at this, and we research all kinds of things, but I think this is a real area because I think it will be linked to better outcomes in terms of experience and perhaps even mortality, perinatal mortality and prematurity. Women are well able to give us advice and to partner with us and to make those decisions and to make better decisions because we're taking into account more elements, more components. And perhaps the converse will be true where we don't do that. We just propagate health inequality and we propagate perhaps adverse maternal and infant health outcomes. I'm going to finish there because I've taken up too much time with all the slides, but it is about dignity. It is about autonomy, it is about bodily integrity, but fundamentally, informed consent says that I respect you as a human being and I want to do everything that I can to ensure that we work together so that the outcome in this scenario will be the very best it can be. And that is a good goal to have. Thank you.
Thank you, and that's a very powerful statement on which you end there, Rona, and a very important statement. I'm very happy now to turn to our next panellist, and that is Winnie Ryan. Winnie is the National Healthcare Communication. She works with the National Healthcare Communication Programme. She's working specifically in the area of leadership, education and talent division in terms of that programme. She's currently working with HSE Acute Hospitals Division on the development and rollout of the National Healthcare Communication Programme. And it's obvious, I think, that her work is very, very important in helping to deliver on some of those points which Rona and Gráinne just made. So thank you very much, Winnie, for joining us.
Good morning, everyone. My name is Winnie Ryan. I work on the National Healthcare Communication Programme. I co-facilitate the programme with Professor Peter Gillen. Peter is an Associate Professor of Surgery in RCSI and a retired surgeon. The programme was set up in January of 2018 in response to the first National Patient Experience Survey, which happened in 2017. And that survey identified that communication between patients and between healthcare providers was an area requiring improvement. Our programme is a collaboration with EACH, and EACH are the International Association for Communication in Healthcare. They are mainly composed of clinicians from all around the world who are interested in teaching communication skills at postgraduate and undergraduate level. So moving on to the National Maternity Experience Survey that Gráinne has spoken about already, or the NMES as we call it for short. The Maternity Experience Survey gives women the opportunity to share experiences of their care in maternity services. And the survey is supported by the Department of Health, by HICWA and by the HSE. So women who gave birth in October and November of last year were invited to participate in the survey. And you can see the numbers there on the screen. Over 6,000 women were invited to participate. We had a 50% participation rate, which is very high for this type of survey. There were 68 questions in the survey, and when we looked at those questions, 41 of them related to communication. Now, the questions themselves were analysed by HICWA, and they published their report on the findings of the survey in October of this year. During the summer, in the National Healthcare Communication Programme, we read all of the comments that women made. So there were 3 open-ended questions in the survey, asking women about what was good about your experience of care, what needed to be improved, and any other comments you wanted to make. And we have worked to date on, this is our fourth survey that we've worked on. We find the gold of the survey is in the comments. That's where women take the time to write free text responses to those questions. So we read through all of those comments over the summer and analysed those. The analysis of the comments was done using the Calgary-Cambridge Guide, and for those who mightn't be familiar with it, it is an internationally recognised evidence-based framework dealing with communication skills, and it's used to teach communication skills all around the world at undergraduate and postgraduate level in medical schools and nursing and midwifery schools. And it provides a structure for the consultation, starting with how we initiate the consultation right down to closing the session. It outlines 71 communication skills that we teach in our programs. That's a lot of skills, and we don't expect people to use all of those skills in every consultation, but they're the skills that are needed. What was very interesting for us when we analysed and looked at the comments, if you remember, there were over 6,000 comments, but actually over 5,000 of those related to communication. So what that is telling us, and that's different from other surveys, while patients would have commented on communication in other surveys, they also commented on facilities, on the hygiene, on food and nutrition and hydration. Women are mostly interested in how we communicate with them. So that's the first point that we would make. What was also interesting is when we looked at those comments, some of the comments fell under every element of the Calgary-Cambridge Guide, but the majority of comments fell under 3 sections of the guide. The first of those was building the relationship, and Rona has spoken about this, about building rapport with the women. So over 3,000 of the comments related to how we build rapport with women. So that's, women are really, really interested in how we communicate with them to build a good relationship with them. The second area was gathering information. There were over 700 comments here on the skills that we use to listen to the woman, to encourage her to tell her story, to tell us what she's worried about, what her ideas are, what her expectations are. And then the last main area was how we give information. We call it providing information and planning, and there were over 1,000 comments in relation to this area. So they're all the analysis of all the comments. Other areas that were covered were teamwork and handover, delivering bad news. There were a very small amount of comments on disclosing errors and comments relation to consent. So when we looked at all of those comments, when they were analysed, we extracted the comments where women mentioned consent in particular. Now, there were 57 comments that we identified relating to consent. So when women talked about consent, they talked about the information they were given, as Rona was saying, about the risks, the benefits, the options, the alternatives. They also spoke about consent for procedures like episiotomy, like induction, like sweeping the membranes, like rupturing the membranes, having students present during labour, and also demonstrating breastfeeding techniques. 2 of the comments in relation to consent were positive. I'm going to show you those now in a moment. And I'm not going to read them. I'm going to give you a moment just to read those comments yourself. So these were the 2 good comments, positive comments that women made. So they're about information, about the risks involved, and not feeling pressured and feeling that the woman had a choice. So as I said, there were 55 comments then that were opportunities for improvement. And although they are small in number, they're very big in impact, because what women said to us is when they were writing these comments, women mentioned that I'm crying while I'm writing this comment, I'm still traumatized by this event, I'm so traumatized by the event that I will never go back to that hospital again, or I might never even want to go through pregnancy or deliver a baby again. So obviously there are areas that we do need to look at. So I've selected 4 of these comments for you to have a look at. And again, I'll let you read them yourselves. Information in relation to the options around induction, Breaking waters came up quite a bit in comments relating to consent. And another 2 comments on this screen. Okay, so again, consent is required for every intervention, and also the timing of the procedure, when information is given or when the consent process is started. Okay, so what are the challenges? And Rona and Grania have referred to these already. For the woman, I'll let you read those yourselves, but we have to remember, I suppose, that for the woman, while childbirth can be a wonderful experience, it also can be terrifying, especially if it's the first time a woman has given birth. So women will feel scared, stressed, overwhelmed, intimidated. There might be language barriers. Rona's referred to, health literacy or maybe cognitive impairments. For clinicians, there will be time pressures. A lot of the women in the survey noted that, the clinicians, the doctors and the midwives never seem to have enough time. They're so busy in the work that they do. Sometimes there's an over-reliance, as Rona said, on medical jargon, and also if the clinician doesn't have good communication skills. It's very important to remember as clinicians that the person's language skills and ability to take in information will diminish under stress. So any encounter really with healthcare can be stressful, but in particular in childbirth or during labour, the woman can be under a lot of stress and her ability to take in information is going to be reduced. So we need to take that into account. The second thing we need to take into account is that it's not just the woman or the person who will become stressed, but clinicians can also become stressed too, particularly in emergency situations. And when we look into this, we note that what happens in emergency situations is clinicians, and when I say clinician, I mean doctors or midwives or healthcare professionals, we tend to become very task focused. And we need clinicians to be focused on the task because we want the delivery of a healthy baby and a healthy woman. But we also need our clinicians, particularly in emergency situations, to use good communication skills. Because in an emergency situation, the woman will remember everything that was said to her because it becomes a critical moment in that woman's life. And that saying that we hear that Maya Angelou said, I might forget what you did, I might forget what you said, I'll never forget how you made me feel. And that's all about our communication skills. So good communication skills are never more relevant than during an emergency situation. And what are the skills? When we talk about consent, we look at consent as a process. So it's not a one-off event, and it includes all of the skills that the women identify that were important to them in the survey. So women need to work with a clinician in whom they trust, who understands their condition or whatever their area that they're involved in, who understands them as a person, and who can share information with them in a way that they can use, they can recall, and they can understand. So what are the skills? We would say the first set of skills are the skills that Grania referred to, how you build a relationship with the woman. So actually consent as a process begins with, hello, my name is Winnie. I am your doctor or midwife here with you today. All of those skills, and I'm not going to go through them all in detail, but these are all the skills we use to build a good relationship with a woman. If you build a good relationship with people, then they are more likely to trust you. So moving on to skills for gathering information. Sorry, I can hear the bell also there. I'll move along, Marie. So skills for gathering information. If I use good skills for gathering information, then I'm hearing the woman's story. I'm hearing her perspective. She is telling me what she's worried about, her ideas, concerns, and expectations. And if I've done those 2 steps, so I've built a good relationship, the woman trusts me, she knows that I'm listening to her, she knows that I understand her perspective. When I know her perspective, I can incorporate it into the information that I give her, but the woman herself will now feel more confident to ask me questions if she doesn't understand. She might challenge me if it's something that she doesn't agree with, and together she's more involved in the process, and together we can plan what the decision is going to be. We run, as I said, we run workshops for communication skills teaching, and we'd like to commend Grania and the other directors of midwifery on all the maternity sites who've engaged with the programme and sent their staff along to train them to be facilitators for our programme. Now, during this time, we're actually running our Train the Trainer sessions virtually, and then on site, staff are running the workshops, the communication skills workshops themselves, applying all of the guidelines for COVID. We find when staff come to our workshops, this is what they say to us. And I suppose if you were to liken it to driving, I learned to drive a long, long time ago. If I was to sit with a driving instructor today and even just spend an hour with him or her, I'm sure they would be able to point out to me, skills that maybe I've forgotten along the way or areas that I could improve. So all of our workshops are experiential, where staff get the chance to practice the skills using scenarios that we have developed with them, and then we give them feedback so they can improve. So finally, Marie, I'm just about to finish. Just 2 takeaways. What I have learned in the last 2.5 years working on this program is that the skills we use for listening are the most important and underutilized skills in healthcare. It's very important to listen to the woman's perspective. And we are doing that. We're taking the results of the maternity experience survey and applying them to our communication skills training program. And for our clinicians, we know that clinicians, as Gráinne said, are absolutely doing their best. And it's difficult, particularly at the moment. We know that most of our staff have never had communication skills training at undergraduate or postgraduate level. So we are here to help you, to support you, to develop those skills, enhance them and improve them. Thank you very much. And I'm very sorry about the video, but I hope you were able to get the sense of the presentation there. Thanks, Mary.
Thank you very much, Winnie. That was fantastic, and your slides were wonderful, and the voices that you presented were absolutely fantastic. And I guess reinforce the efforts that are being made to give effect to, I suppose, all the points which both Rona and Gráinne identified so effectively. So thank you very much, Winnie. And actually we continued on the theme of voices and the voices of people who use services as we turn to Elaine Mccauley for the next presentation. Elaine has extensive clinical experience as a speech and language therapist. She also has an LLM in healthcare ethics and law from the University of Manchester. Her current role is the Education and Training Coordinator in the National Office for Human Rights and Equality Policy. So I'm delighted to turn over to Elaine now. Thank you, Elaine.
Thanks, Mary, and thanks to all the other presenters for great presentations. As Rona and Gráinne had said, the woman is really the key decision maker about her care, and Winnie has provided us with an excellent analysis of the comments from the National Maternity Experience Survey. I suppose, as Winnie mentioned, there is no specific question in the National Maternity Experience Survey about consent, and similarly there's no explicit question about consent in the National Patient Experience Survey. So I suppose to add on to the information that Winnie has presented, I carried out a number of interviews with women across the country and asked them about explicitly about their experiences of consent in maternity services. So I'm going to try to play those now and give us all an opportunity to practice our listening skills. I'd like to take this opportunity to sincerely thank those women for their generosity in sharing their stories and their insights with us. So I'm really pushing myself to the edges of my technical know-how here. I hope this works. We will lose video when I play the audio, so I won't panic if you don't.
And I'll shout to confirm to you, Elaine, that we're all fine.
Super. Okie doke.
What does consent mean?
I suppose it's somebody giving you all the information in regards of what they're planning to do or what they think is the right option, and giving you all the information and letting you decide with them.
Asking permission, explaining, providing information. From my perspective, it would be verbal consent because I'm able to actually communicate verbally, but there are other ways to get consent as well.
So I suppose it's just being like informed and part of the conversation. I suppose the last thing you want is just to feel like you're lying on the table and you don't know what's going on around you.
I think to me consent means when you fully understand a situation and what the options are and what the consequences are. Consent can't be given unless you do understand the options and the rationale. It can't be given under pressure.
I had to have my initial assessments, which was carried out by a midwife. My mother was there and she asked me whether I wanted my mother to leave the room or whether it was okay for her to go through all these questions, which she knew would be private, in front of my mother, and I verbally consented to that. I had to get a sweep. I verbally consented to that. I think it was all done well. You weren't just told that you had to do this. I suppose you were given choices. I think I was given information about if I don't do it now, what would happen? If I did do it now, what would happen? When I was 39 weeks plus 4, I was told I had low fluid, and they told me that they felt like they needed to induce me. And I really didn't want to be induced. They explained to me what the pros and cons at that point would be to getting induced. I asked them to really explain why, in terms of if I didn't have it done right now. They did go through with me what would happen. What we negotiated was that we would wait a few days and then they would induce me. And again, I did verbally consent to that. So I think they gave me that time, which was important.
Pethidine, I never realised pethidine makes you so drowsy. I mean, you're not even able for labour then, but they didn't have the time to explain that to me, that this is what will happen when we give you pethidine. So I suppose when I was put on the oxytocin with the last 2 pregnancies, they just told me I was going on a drip. They told me obviously I wasn't progressing, but I didn't know what was in it. And I didn't realise how the labour would change so quickly. Nobody explained to me how strong the contractions get and how more frequent they come when you're on that drip. And then they put up the amounts that are in the drip. Nobody said to me, we're going to put this up. Is that okay? Or anything like that. It was done. So that was probably a time where I felt they should have said to me, this is what we're going to do and this is what's going to happen when we do it. I mean, like maybe I needed it and that's fine, but at least talk me through it. I was scared at the time, I was anxious and I was nervous and I didn't feel like I could say stop or ask a question or say anything. It affected after when I had the baby.
When I was about 9 weeks pregnant, I had a bleed. They referred me to an early pregnancy unit for a scan. It was my first child. I was really scared and I thought I was having a miscarriage. And the doctor was really lovely, really reassuring, and asked if I would consent to a vaginal examination. I've got a history of sexual violence, so I'm really uptight as such about any interference. And so I asked if there could be a female doctor, and they did that. They got a female doctor for me. Before the doctor did anything, she explained what exactly she was going to do and why it was important, and talked me through everything. And so I felt more at ease, and I felt that I was really being listened to. And to me, that was a really positive experience.
The experience was that I was having a really lovely, empathetic relationship with the midwife, and I felt very part of every decision that she was making. And then the consultant came in. Because she was just doing her job and she had a job to do, I almost fell out of the equation. I was just, part of her job. She just didn't involve me in any way. Her conversation was over my body. I was just left there on the table until the conversation was done. So it just left me feeling really like a piece of meat, to be honest.
I visited I think they're called VBAC consultants. She told me the different options I have, because at the last pregnancy it ended in an emergency section, and whether I can go naturally this time or have a section. And she was one of the first people that said, you have the chance to make the decision. It's up to you. Whereas prior to that, having talked to midwives and consultants, they were telling me what was going to happen the next time. That was a big deal. That was the first time I realised that I have a say in what happens when I give birth. I suppose I felt a lot calmer afterwards. I think it's a really good service. I mean, having somebody just to sit down and go through your options is huge.
I would suffer from anxiety, so I had been preparing myself physically and mentally for labour and trying to set aside the anxiety around it. I knew what I wanted and what I didn't want to happen, but I understood that sometimes things can take a turn. But I found in my interactions with consultants, and it wasn't necessarily the consultant, maybe the consultant of the Reg or the SHO, I found them disempowering. I just didn't feel like I was being taken seriously. One of my last antenatal appointments, the doctor said to me, we'll book you in for an induction at this point. And I said, no, I don't want to have an induction. And she said, well, this is our policy. This is what we do. And I said, with respect, we'll cross that bridge when we come to it. I understand what your policy is. I said, I know what I want. I understand the risks. I understand the benefits. And so she was very dismissive with me, kind of like, you think you know it all, or some sort of a quip. And I thought, that's horrible. Like, I don't know it all, but I know enough to know that I don't want something or I do want something. When Cyril was born, I wanted delayed cord clamp in. They said, oh, we have to cut the cord straight away because the paediatrician was in the room. Before the baby was born, I said, oh, when the baby comes out, I want to delay the clamping. I knew all about the benefits of it. And they said, no, it has to be done straight away. And there was no reason for that at all. In those interactions, the doctors weren't interested in the fact that I was informed. It would probably be better for them if I wasn't informed because I would just go along with what they were telling me to do. So I felt it was disrespectful and dismissive. I understand that doctors are experts in their field, but it's my body. It's my life.
Before we had our daughter, we had an ectopic pregnancy. And so I suppose the nature of that is they just didn't actually have a clue what was happening. Like nobody did, because it's so early. You have to wait and see, you know. And so, but I felt like at that they gave me all the information that they had at every point. It was like, and even if that was like no information, I felt like very part of the conversation there. At one point I went in, I had to go into the emergency room because I had a bleed. And there was a really lovely doctor and she was just like, look, I'm not going to lie to you, this is going to be zero crack. And I think even that was a kind of form of her consent before she put the speculum in or whatever, that she was kind of going, here's the little contract between you and I, it's not going to be that comfortable, are you okay with that? And that was, you know, that kind of both relaxed me and informed me of what was about to come, you know. I really did feel in good hands. I understood that this woman was an expert. So it's kind of like the knowledge part, but also the empathy part. There's nobody forcing me to do anything. I'm just being given all the information, but also in a human way.
What would help improve consent practices in maternity services?
I think looking at a person is really important. When somebody is sitting in a hospital bed or in a chair and somebody's standing over them or not looking at them, you immediately get this impression that, number one, they're not listening and they're not giving you any time. And there's such a difference between that and if you sit down with somebody, look at them and say it to them, it just makes the person feel completely different.
I think drugs mainly for me, if you're going to give them, inform the patient of what's going to happen next. I suppose to realise that some people don't have a medical background, they don't understand, and things might need to be explained crystal clear to them. And to take the time and then maybe just ask the question, have you any questions? Is there anything you're concerned about? Simple things like that can help. Obviously, in an emergency situation, there isn't always the time. So maybe afterwards, take the time to explain why that happened.
Doctors and nurses should focus on information and keep away from emotion. Provide the information and respect the woman and her partner enough to accept whatever decision they come with. When you feel under pressure and the choices are being taken away from you and things are being done against your will, when you know that there are negative consequences there, it's usually scary. It's not helping women to stay healthy.
Just to kind of have a human connection, which I feel like most people, most midwives and nurses do, and most of the consultants I kind of came across did too. It's just the bad experience I have was exactly that, where they didn't do that, where you don't feel human, you just feel like a cog in their job. So it's just remembering that it is a human, and although it's something you probably do every day, you know, working on these bodies and doing X, Y, and Z, you know, but it's just taking a second to breathe and go, okay, this is a new person. How do I treat this person in the way that I would like to be treated if I was sitting in that chair and I was scared and worried and all of those things?
Fantastic. Thank you very much, Elaine, for that. That was absolutely fantastic. I want to apologise because I think some people have had difficulty saying that they couldn't hear the audio there. Just to reassure you that we will be putting this up on the website and the audio will be working there. And I see a question coming in on the interviews. We'll address that later. So the audio will be playing. You will be able to hear it. And just to say to those of you who didn't hear it, certainly I think most of us would agree that it is so worth listening to. It is an extraordinarily powerful set of statements, which I think really reinforces everything that we're trying to do today. And so with great delight, I turn to our last speaker of our last panelist of the morning, and that is Dr. Joan Mccarthy. Joan is a senior lecturer in the School of Nursing and Midwifery in University College Cork. She's also a visiting professor in the University of Surrey. She is a an ethicist, a feminist, and a very powerful speaker. And we're really delighted that Joan has joined us today to give us her perspectives on ethical issues in pregnancy and childbirth. Thank you very much, Joan.
Thank you, Mary, and thanks for inviting me to contribute and to follow on the women's voices, their expertise, their experience, their authority over their own pregnancies and childbirth is inspiring, to say the least. So I'm going to talk about ethical issues that arise in relation to consent in pregnancy and maternity care. And I think those ethical issues must be understood in terms of the background that we've already seen, that carrying a pregnancy and undertaking labour, childbirth and postnatal care is indispensable work that makes a profound and significant contribution to human life and human community. And it requires continuous self-management and self-regulation. Clearly, it impacts on the physiological, psychological, social, emotional health and well-being of the pregnant woman, as well as on the health and well-being of the fetus. It gives rise to ethical challenges because fundamental rights and interests come into conflict and ethical values are at risk, including bodily integrity, inviolability, autonomy, health, well-being, human life, justice. Okay, sorry, I'm too fast there. So, yeah, sorry with the slides there. Okay, so the relationship between the woman and the fetus and the way that relationship is framed or understood is crucial to the way in which the pregnant woman is treated in law, policy, and clinical practice. But how it's framed is complex and contested. Is the relationship one between separate entities where the fetus and the woman are distinct? This perspective leads to an emphasis on fetal rights. Is the relationship one of part and whole where the fetus is viewed as part of the woman's body? This leads to an emphasis on women's rights. Is the relationship not one, but not two, where the emphasis is on the unique interconnection and interdependence of the pregnant woman and the fetus? This kind of unique duality. Katrina McKenzie says this best, and I'll hold on to her quotation here. The fetus is not simply an entity extrinsic to her, which happens to be developing inside her body. It is a being, both inseparable and yet separate from her, both part and soon to be independent from her. And it's this kind of duality, a unique duality that's captured in the view C, there's a fairly wide, or at least growing consensus around this view of pregnancy. And this leads to an emphasis both on women's rights and their responsibilities. And how is this reflected in Ireland? Well, as Mary actually mentioned at the very start of today's session, there's a seismic shift, if you like, has happened in Ireland pre and post the 8th Amendment referendum in May 2018. Pre-2018, the fetus from its earliest stage had the same legal standing as the pregnant woman. So the view of the relationship was closer to position A that I've just mentioned. And this led to chilling and tragic examples of efforts and decisions made by the HSE and Irish courts to compel pregnant women to undergo medical interventions or forego medical treatment in the interests of the fetus. And Rona has already mentioned the case of Ms. P. Post-2018, there's an evolving legal, social and political consensus that the fetus has moral and legal standing, and that standing increases as the fetus develops towards becoming a person, but that it doesn't have the same rights as persons. So this brings us closer, in my view, to position C, where we're focusing on women's rights and also their responsibilities. And I think this is reflected in the 2019 HSE informed National Consent Policy. I'm not the HSE now, of course, but this is my understanding of how this new situation has been grasped by the National Consent Policy published in 2019. And it focuses on a level of information that health professionals must meet in terms of pregnant women. So they must receive sufficient information, and Gráinne mentioned this already, in a manner that is comprehensible to them about the nature, purpose, benefits and risks of an intervention on their health and life. But they also need sufficient information about the benefits and risks of the intervention or lack thereof on the viability and health of the fetus, and they need sufficient information on the benefits and risks on the viability and health of the child that will be delivered. So in short, the way I see it is that the consent policy holds health professionals to the same standard of information for pregnant women or information provision as it does for non-pregnant people, while recognising that the woman's decision impacts on fetal life. The HSE National Consent Policy in 2019 also sets standards of consent that are important to understand. It makes it clear that health professionals are required to secure the consent of the pregnant woman for any medical intervention up until the birth of the baby. The obligation to respect autonomy in the policy equally applies to pregnant women. So, in other words, health professionals must respect the service user's woman's right to self-determination, the right to control her own life, to decide what happens to her own body. Service users and women are the ultimate decision-making authority, are the experts over what ends matter to them, how they should live their everyday lives, decisions about risk-taking, preference for privacy or non-interference. And it also specifies, importantly, that treating competent service users, including pregnant women, without their consent is a violation of their legal and constitutional rights. So a lot is clear now, but I think I want to talk a little bit about some tensions that I'm imagining will persist and do persist in other jurisdictions. Because while policies and laws, such as now the National Consent Policy, recognise the rights of pregnant people are on a par with non-pregnant people, in practice this might be undermined. And a particular place where they're undermined is where refusals of clinically indicated treatment often prompt questions about the woman's capacity. There's much to say on that point, but I'll just leave it as the point made and for people to think about. But it also, those kinds of conflicts around refusals can be exacerbated by advances in medical technology, which enable the fetus to become visible as well as accessible through, for example, in vivo diagnostic and surgical interventions. Technologies such as ultrasound scans, though they're often welcome, very welcome indeed, they visually disconnect the fetus from the pregnant woman, suggesting it's free-floating and separate from her. These technologies can also reinforce medical authority and scrutiny and diminish the woman's knowledge, her trust in her own experience, and her commitment to do everything in her power to ensure the best possible start in life for her child. And so very briefly, we just have a picture here from the National Maternity Experience Survey report, which, as you can see, positions the pregnant woman on one side. Over at the other side is this kind of free-floating fetus, and the health professional is between the two. A further tension, I think, in terms of delivering on the high standard of informed consent that we want in place is the context of decision-making. In everyday situations, not even the sort of dramatic, traumatic and emergency ones, in everyday ordinary situations, how easily can women dispute what doctors and midwives ask of them? The context within which they're making decisions is significant, because in the clinic, there's an asymmetry automatically, well-intentioned or unintentioned, an asymmetry of authority and control between the health professional and the pregnant woman, whatever authority she may have or lack in other contexts before she comes in the clinic door. In addition, structural factors such as class, race, gender, and ability shape and constrain the decision-making process in different ways, such as lending credibility to some voices while filtering out or discrediting others. These asymmetries suggest that a woman's consent to treatment may resemble acquiescence more closely than actual agreement and ownership of the decision. So to conclude, reciprocity on the part of the state and society in general for the indispensable reproductive work of pregnancy and maternity sets a high bar for the quality of services and supports that should be put in place. So in other words, the work that the informed consent process has to achieve is the very minimum that should be happening here. Obliges health professionals and organisations to ensure that these services are genuinely woman-centred and inclusive, involves shared decision-making, where both women and professionals are recognised as experts, and asymmetries of power and authority between them are reduced, or the work is there, efforts are made to reduce those asymmetries. And I'll just come back to shared decision-making again shortly. Offer meaningful and realisable options regarding who assists women, where and how, and include advanced planning to build trust, which I think is central to all of this, and cooperation, as well as anticipate conflict and avoid it. And just to say back to the shared decision-making, our colleagues in Trinity, Begley et al., have written a very good paper defining what shared decision-making in maternity care specifically is, and I think it applies indeed in general to all of the health services. So that's certainly worth taking a look. And I've also, of course, added in references at the end to the literature that I've drawn on presenting this paper. So that's the end of me, and thanks very much for listening.
Thank you so much, Joan, with your trademark clarity and ethical sophistication. So thank you. We really do appreciate that. And it's wonderful to have the ethical kind of underpinnings and the complex ethical underpinnings reinforced. This is not a straightforward area, and I think your division is absolutely fantastic. So thank you very much for that, Joan. So we're going to turn now to questions, and it's wonderful. We have almost half an hour for questions. We're very grateful for that. So we'd ask our speakers, if you don't mind, to put your mics back on. I'll start throwing questions at you, and I hope, and do feel free to bat them back if you don't want them, or if you think somebody else could deal with them better, but we'll be doing our best. Try to get through as many questions. We've had a really good response from chat, as many of you will see. I'm actually going to start with a couple of questions, though, which came in advance of today. So I'm going to start with those couple. And the first one is, what are the plans to communicate consent rights and processes in pregnancy and maternity care to women and pregnant people? And it's the questioner asks, we believe there's a need for a wide-ranging communications and health education campaign. And that question is one of two from the National Women's Council of Ireland. And I suppose this, in a sense, is the first part of that process, which is recognising the importance of communications. And Winnie's work, I guess, there is also reinforcing the importance of communications there. Elaine, do you want to say anything on that, Elaine, or Winnie, on that, or have I addressed that sufficiently there?
I think you're right in the terms of the roles of the webinars in this as a starting point. Our office did actually carry out a survey with Red C online at the end of 2019, and there was actually quite a high rate, 66% of the general public surveyed were aware of the requirement for consent for any health or social care interaction. So I suppose that is positive. In terms of whose responsibility it is, or any kind of campaign, as the question mentions, I think really it's everybody's responsibility. I suppose everyone working in this area has a role in terms of empowering and helping people who use services to exercise their rights to consent and to support them and educate them around that.
Thanks very much, Elaine, and I think that's something which is very true. There's an enormous amount can be done, but by quite a lot of people can contribute to enhancing. And as Joan said very fairly there, things we have had a seismic shift, and we really need to, in the wake of the referendum, and we really need to bed that down. The second question, which I'm going to put to Rona first, and then Grania, if that's okay. What are the implications of the current COVID-19 restrictions on partners at scans, appointments, early labour and post-labour for women's consent during pregnancy and maternity care? So that's the first part of it. And then there's a second part which looks to which actions are currently being taken to ensure that consent rights are maintained during this period. And I'm assuming period there refers to the period of the COVID-19 restrictions.
Yeah, no, thank you. I think it's so difficult at the moment for women, embarking on this very complex journey of having a baby, not to be able to have their partners with them for those visits. Very often women come in for a scan, there may be unexpected news and women find themselves alone. And equally, it gives everyone huge anxiety. And will partners be able to attend? There can be confusion about information. Different hospitals have different procedures in place. We all understand the reason for those, which is, an effort to protect us. We're all learning in this pandemic, and we're dealing with very vulnerable members of our society. But it is a huge issue. At the end of the day, women will always make their own consent, if you like. They are adults and they will have that capacity to make consent. Consent would not really be made on their behalf by a partner. But partners are advocates. And, a big part of what we discussed today is that whole assimilation of information and that able to have that discussion and just that support. So I think it is a real issue for women, although, as I say, they will always make their own decision. In terms of how we can get around that, I think it's very important that we as clinicians are very conscious of our need, again, to communicate as clearly as we can. Sometimes we link with FaceTime videos, we link with allowing people video maybe during a scan. I've even had conversations, on FaceTime with partners. And sometimes we would also get around restrictions in, times when there are really difficult issues happening, and we will allow partners in when we know that there's a real problem. We are compassionate about it, and we always retain that little bit of flexibility. We have put a lot of information on our website, I think, around the hospitals in the country, and that is an effort to improve that information that's available. There are still antenatal classes, and we can still manage something of a one-to-one combination using Zoom calls and using the technologies and using the information. But there's no doubt about it. It is an added stress, because very often one of the chief advocates for women is their partner. Although we do have one-to-one midwifery care during labour, which is often the time when big decisions are made. And midwives are tremendous advocates. They're with women all the time during that labour. As clinical staff, as doctors, we tend to come in and out. But midwives are there for the whole labour. I think that's very helpful and allows that opportunity conversations to arise as labour and events pan out.
Thank you very much.
Yeah, I'll just add, I suppose Rona has really explained it eloquently there, but I suppose in enforcing what I had said earlier about the role of the midwife, is that, we are there as advocates for women. It's that piece around the continuity of carer, where that relationship and trusting relationship has been built up. And I suppose, again, we do individualized care and care plans for women. So there are circumstances, as Rona had said, where we will allow partners in, based on the circumstance. So we risk assess every situation, and each hospital is different, and you have maternity units that are co-located like ours, and then you have standalone maternity units, and they have different issues of concern in regards to the safety in relation to COVID-19. But I suppose at the heart of everything we do is the woman, her partner and her baby, and I suppose the same thing, I suppose it's just heightened now in this COVID-19 is a pandemic that we never envisaged and have never been through before, and the huge important role of that continuity of care and what the midwives can do to support women, which start, as I say, from booking all the way through building up that trust and that relationship with the women or the pregnant person.
Fantastic. And while I have you, Grania, before you go, if I could throw another one at you, which is, I don't know if you've had experience of this, which is a 15-year-old or 14, 15-year-old pregnant young woman, or indeed 16-year-old. And I'll talk a little bit around some of the legal frameworks in a minute, but if you wouldn't mind sharing your wisdom on that, please. And I'll ask maybe Rona about that as well.
Yeah, and I'm happy to answer that question. We have a clinical midwife specialist in teenage pregnancy. We're the first clinical midwife specialist in teenage pregnancy in the country here in Our Lady of Lourdes Hospital. And if it is a 15-year-old that's pregnant in relation to consent, by Irish law, that person is underage to have had sexual activity. So they do come under the Child Protection Agency. Now, that doesn't mean to say that they cannot consent, but they actually have to consent in partnership relationship with an adult or a carer. So the parents, obviously, if there are parents, or a responsible adult who has been delegated as the carer for that person. So any person who is 13, 14 or 15 that's pregnant, they do come under the Child Protection Services, and there would be social work involvement. Up to the 16-year-old, and yes, a 16-year-old can consent, obviously, and sign consent for bloods. But if that person became pregnant while they were 15, but are now booking at 16, they actually still fall under the the Child Protection Agency, because they became pregnant at underage.
Fantastic. And then in terms of, if I might just ask, in terms of information and everything, I'm assuming the young woman is given exactly the same amount of information and all of that.
Yeah, absolutely. And everything that we said about consent to now, it's consent for any age. So, you know, we have to take into consideration, though, when you're talking to somebody and you know, at 13 or 14 or 15, you know, their level of understanding. So one of the things that we talked about earlier was language and the use of supporting documentation. And that's hugely important, you know, when you're talking to somebody who may not understand what we're saying. So you have, as I say, the medical profession there explaining. That's reinforced and supported by information from the midwife, and then, you know, it's that informed decision making, informed consent in collaboration with the person who is their carer. So it's a huge team involvement with pregnant people who are at that age.
Fabulous. Thank you very much for that, Grania. Rona, would you like to add anything to that in terms of, again, your own experience?
Yeah, I mean, I think, again, it's very important in these circumstances. You know, Grania's laid out brilliantly. I have really little to add, but just that it is about also listening. Just because someone is 15 or 16 doesn't mean that they have very strong opinion about what treatment they would like or not like when they're given the information in a way that's understandable to them. So it is really important that, as far as possible, no matter what age anyone is, that we are still respecting their integrity and their autonomy. And as has been mentioned, that's often done in partnership with the responsible adult. And we do encourage that, you know, particularly with parents, that people under 16 would make decisions in conjunction with a loved person, a family member, someone they really trust. So again, that advocacy piece, I think, is never more important. But 16 is a particular area we have in the UK, people looking at that mature 16-year-old, and it can be a really difficult age, because I remember being 16, I thought I was very grown up. I look back now and I'm not sure if I'm grown up yet. But I think it's very important that we have respect for this age group, and that we do listen. And I think it's about listening. So much of what we're talking about today actually is about the importance of listening to what a patient is telling us, and that doesn't diminish because of age.
Fantastic. Thank you so much, Rona, for that. And again, just to reinforce the point which Grania made, which is the particular legal situation, which is, I think, far from ideal. Our Irish legal situation, it lacks the kind of clarity that would be really helpful. And we're trying, and we are reworking the National Consent Policy to try to give the clearest indications we can. But the legal situation is not ideal. It's not as clearly stated regarding, for example, people under 16. But the key point coming through there is the absolute importance of involvement, participation, all the information rights, and making sure everything is drafted and for the person, with the person in mind. While I have you, Rona, if I may, we've had a query, in kind of a double query. One relates to 22Q11, I guess, syndrome, and in terms of the amount of information which is made available on that. So that's kind of the first part of the query. And then the second and more general part of the query is about people with intellectual disabilities and how they can, and I know you addressed it in part in your discussion, how they can be facilitated in terms of decision making around pregnancy. Thank you.
Yeah, I mean, obviously 22Q11 is a very specific deletion. It can be associated with a condition called DiGeorge syndrome and with cardiac abnormality particularly. And we would generally screen a fetus for this if, when we're scanning, we pick up a cardiac difference or a difference in how how the anatomy of the heart is put together. There are other consequences, including developmental delays that are associated with this and deletion. So really, we don't always pick it up before birth, but where we do, it's usually in the context of a structural difference, and therefore we have an opportunity, I suppose, to give parents as much information as we have, and that will be in discussion with genetic team, with cardiologists. Often it's a very multidisciplinary team with written information, and looking at the long-term consequences of what that might mean for the babies. That would include the neonatal team. So really, it's about giving as much information as we can in advance. And then obviously it fits into, it is one area where we can see developmental delay and some intellectual disability in later life. And I do think the issue of intellectual disability is so important, and it's really beyond my expertise probably to address it fully. But I think the fundamental principle is the idea of assuming capacity. We must start off with the premise that a person does have the capacity to make a decision, and we must look to see what can we do to facilitate that person to make a decision. So if it means additional educational material, talking longer, talking more, giving simpler information, using videos, using aids, then that's what we must do, because ultimately we want that person to make their own decision, and we must not label people and assume that they are unable. There are legal systems there, like boards of court, etc., that can help as well. And obviously we have to explore those options where we feel perhaps we're not getting the right information, or we feel that a patient really isn't having the opportunity to assimilate that information. And then obviously there is, a bill that is coming through at the moment that will help to streamline those. I think that's very important, because at the moment, some of the legislation dates back to 1871. It's very old legislation indeed. And I think it's really important. And I know this bill has been in the making since about 2013, but I think that's just so important. But I can't say enough. You must start with the premise that a person does have the capacity to make a decision, and do everything you can to assist that person to have that capacity. And that's the fundamental principle.
Fantastic. Thank you, Rona. Grania, any experience of this that you'd like to add or share in terms of facilitating people?
No, I suppose just in relation to midwifery training, as part of that, we would do a piece on, disabilities, early childhood development, and we have a module on sensitive midwifery, and that includes issues on, and scenarios where maybe people don't have the capacity. So that, that's included in that. And also we would have different advocates and support groups, representatives in to speak to midwives during their training as well. So yeah, I think probably that's all I need to add.
Fantastic. Elaine, do you want to say anything in terms of the work of the Human Rights and Equality Centre, or unit, I should say, HSE, around assisted capacity and role of advocacy? Anything you'd like to add there, or are you content to?
The review of the policy, which you've mentioned, there will be an e-learning programme to support that, and I suppose we would hope to then, after that, maybe run some masterclasses for specific areas such as this. So I suppose focusing on maternity services and these issues that arise. So that would be part of our longer term plan around supporting staff in these areas.
Fantastic. Thank you very much. And just to let everyone know that we had confirmation during the week, a new confirmation during the week from the Decision Support Service that the Assisted Decision Making Capacity Act will be up and running by 2022, and you can see an awful lot of potential around decision-making assistance to assist somebody in the context of pregnancy and childbirth. In that context, you can see an awful lot of work that could usefully be done using the Act to advance things. But of course, all of these things can be done now, even before the Act. As Rona says, we have a presumption of capacity, and it's our job to ensure that we support people to do that and to deliver that. And thanks, Elaine, for talking about the kind of training that's going to be coming down the track. Back to you, Rona, if you don't mind. I think, or Grania, I'll start again if I might with you, Rona. It's how does Ireland compare internationally with maternal mortality?
Very well, actually. So at the moment, the maternal mortality rate in Ireland runs at around 8 per 100,000 maternities, and that's all people who are pregnant. If we look in America, that figure is around 25 per 100,000 in the US, and that's largely down to an inequity of care, which we see there. If we look at France and England, we're looking at around 12 per 100,000, and then perhaps Scandinavian countries, we are looking at around 6 per 100,000. But the big difference is where you go to countries in the developing world, and we see still in countries like Sierra Leone maternal mortality rates of over 300 per 100,000. So there's just such a difference. 99% of our maternal mortality happens in developing countries, and that's 300,000 women who die every single year in childbirth. And many of those deaths are utterly preventable. They are because there is no assisted childbirth and basic remedies are not there. But just think about it, every 3 years, that's 1 million women who die having a baby. And in countries like Sierra Leone, 40% of those deaths are in girls aged 16 or under.
Ooh, thank you, Rona. It's quite a powerful statistic. Grania, do you want to add anything there?
No, I think we'll leave it at that powerful statement of Rona's, like that's something that we need to think about. And although we in this country are very proud of our maternal mortality rate, we can't just look at ourselves. We have to do something and see how we can help the wider world, in education or training, or to see how we can help, because it does affect every woman.
Fantastic. Thank you very much for that. Joan, if I may turn to you, I think it might be just interesting to get an outside, because as you said, you're not the HSE, an outside perspective on this one. And it's, is there a potential, I might then come back to Rona and Grania as well, is there a potential conflict of interest when midwives act as advocates within the HSE? And the question is, are midwives perceived as equal to medics? That's a quote from the question. I thought I would ask Joan to come in first with a balanced ethical perspective, and then we'll go to Rona and we'll go to Grania, if that's all right.
Yeah, I think, first of all, I think that all health professionals probably see themselves as advocates, and certainly listening to today and many other colleagues involved in maternity care and in healthcare generally, whatever their role, nurse, midwife, doctor, speech therapist, obstetrician, would see themselves as advocates. And I think that that's absolutely right. And I wonder at demanding or expecting or even training people to be specific advocates. We are the advocates. I don't think there's any ownership over the role of advocacy. But certainly then in terms of, is there tensions in terms of their role? Yes, because let's face it, there are power asymmetries. That's not saying that there aren't directors of midwifery who are extremely powerful and who can be, who may be as worrying in terms of the way they wield their authority as obstetricians and gynecologists also. So, but certainly the usual, the norm is that there's an imbalance of power in terms of doctors and obstetricians and gynecologists have more credibility automatically given to them. And that's partly to do with the long history of our world and our society, particularly Ireland. But things are changing as well. So I'm sure my midwifery colleagues would believe that, and have actually, in fact, worked very hard to make that change. And I think the training of obstetricians and gynecologists and doctors generally is also emphasising teamwork, multidisciplinary teamwork is the answer to delivering patient-centred, woman-centred, person-centred care.
Fabulous. Thanks, Joan. What do you think, Grania? Do you agree?
I probably don't have enough time to tell you what I think. But okay, there's a couple of things, I suppose. Obviously, this is just a fresh question, but I suppose the couple of things. I don't see it as a conflict of interest with the HSE. I see it that we are advocates, and the thing that guides us, I suppose, within the HSE as employees are to make sure that we stick to the guidance and our policies, procedures, and guidance that is directed to us by the HSE. But I don't think that a midwife in a situation with a woman making an informed decision, and discussing and giving information, ever thinks, I wonder what the HSE is going to think about this. They think about what's the outcome for this mother and baby, and think safety. I suppose that's in relation to the piece on the advocates and the HSE. So I don't think there is a conflict of interest there at all, because honestly, on a day-to-day basis, I don't think any of the midwives on the ground think, I wonder what the HSE is going to say about this. I think, their centre is the woman. Interestingly, in relation to the second part of the questions, are we equal to medics? Again, that's not anything that I suppose personally to be considered. We're two completely different professions with two completely different skill sets. And I think, yes, of course, we've had that, and somebody mentioned earlier, a bit of an imbalance of power where, maybe the consultants are, sorry, Rona now, the consultants, are seen as, like a god-like, person. And that happened many years ago. And and I'm sure Rona is as well, happy to see that is not the case, because we have advanced midwife practitioners who are the primary carer, for these women from, as I said before, from booking all the way to seeing them in their homes, a week, up to a week after birth. We also have, midwifery-led units, again, two, one in Cavan, one in Drogheda. We'd love a lot more, where the midwife is the primary carer. But we work in collaboration. It's not that midwives will ever work in isolation, or consultants or doctors or, obstetricians work in isolation. We work as part of a multidisciplinary team where we respect each other's roles. We have a different set of skills, each of us, and each of us are required as much as the other person. So I think we work completely in collaboration.
Rona, any thoughts, and if you wouldn't mind keeping them fairly brief, because we are...
Absolutely. I've always had I have huge respect. I love working with midwives. It is about collaboration. We are all trying to deliver the best possible care for our patient. Sometimes we're doing slightly different roles. I might be performing a cesarean section, but midwives and ourselves, we work as a team. We are involved, together in the a woman's progress through our hospital antenatally, and indeed during her delivery, and indeed postnatally. I wish our training was less in isolation. Doctors tend to train in isolation, when I think our undergraduate training needs to be much more open to working with midwives, working with the laboratory scientists, working with all kinds of people on our team later on in work. I think our emphasis should be much more on patient equality, actually, and not whether or not midwives and doctors. It's about our patients and how equal we make them in our relationship as we deliver care for them, and that's where our emphasis should be. In terms of 80%, by the way, of trainees in obstetrics are female now. So I think it's not just about the doctor-patient. There can be a male-female issue too. And I think that's important to bear in mind. We're seeing so many more women coming into the specialty, which is great. Power, is there unequal power? Yes. There can be in terms of decision making. Sometimes we see, and there's certainly power in pay. A power imbalance in what the remuneration, and put it there, and also sometimes in career opportunity as well. It can be very difficult for midwives in a clinical scenario to progress. It's brilliant we've advanced nurse practitioners, but I don't think midwives get paid half enough for their experience in direct delivery of clinical care and on the floor. But in summary, it cannot be about a conflict. Because it's about giving the right care. That cannot be in conflict, to give the right care to the patient, but I think we should focus on patients and increasing that equality.
Fantastic. Thank you very much, Rona. I see, sadly, we've run out of time. We've hit the button of 1 o'clock now. We have more questions, which it would be marvellous if we had more time to answer them. But unfortunately, we have run out of time. However, I would like to reassure people that your questions and comments, we will be putting them together. We'll be giving them to panelists, but we will also be taking account of them in terms of developing the consent policy and thinking about, and also I'm sure that they would be very important in terms of Winnie's ongoing work in terms of training and that fantastic work in terms of improving quality of training. But for today, I think that is all we have time for. I would like to thank very sincerely our fantastic panelists. We've been really lucky today, I think. I'd like to thank Rona, I'd like to thank Grania, I'd like to thank Winnie, Elaine and Joan. Thank you very much. Your contributions were fantastic and they worked beautifully together, which is always really nice. They all spoke to each other very, very, very well, reinforcing a message which is the importance of consent in pregnancy and the importance of ensuring that women are, the consent of women, that women are at the centre and pregnant people are at the centre of the delivery of care in pregnancy. So thank you all very much indeed and wishing you all the very best for the rest of your day. Goodbye.